Hey, folks, if you want early access to episodes as they drop, click that subscribe button, join us, and together we'll fix the broken U.S. healthcare system. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host. And today we're joined by Dr. Kyle Rickner, one of the pioneers of the direct primary care movement and co-founder of Primary Health Partners in Oklahoma. What started as 2 clinics has grown into a multi-state DPC network serving employers and patients the way healthcare should work: direct, transparent, and relationship-driven. If you know the Surgery Center of Oklahoma or Dr. Keith Smith, you'll recognize the same spirit here. Doctors stepping out of the broken system and building a better one. We're going to talk about how he did it, why DPC is scaling, and what it will take for this model to become the norm instead of the exception. Let's get into it. Welcome to the big show, Dr. Rickner.
Thank you very much. Glad to be here.
Oh, right on. Thank you so much for joining us and for taking time out of your day to educate, enlighten, and entertain our audience. Appreciate you being here.
You bet. Looking forward to it.
All right, man. So take me back. I want to know, like, why does someone become a doctor? Why? I mean, it's not like the smooth, straight path. You know, none of life is, right? It's all got its kind of curves and winds and ups and downs. But man, I look at, what it takes to be a doctor or a surgeon, and it just blows my mind because it is a commitment.
Yes, and not to be taken lightly. So for me, I did not go to college to become a doctor. I went to college to play basketball. That was my first love, and I had a proclivity for the sciences. Loved that part of it, but I wasn't sure what I would do. And I, by chance, sort of accidentally got a job at a hospital, working in the ORs with a bunch of doctors, surgeons. And it was really that summer experience that made me go, I think I could and want to do this. And so that started my journey. So that was my 3rd year of college. And so started down that path. And I think what got me was, and this will be relevant to our conversation today. At that time, I'm just old enough where none of those doctors were employed by anybody. These were independent, autonomous businessmen who all had their own practice. And there was a certain level of admiration of that from me that I noticed, like, these dudes are their own people, and but yet
Are you still a teenager at this point, or a little older?
So let's see. I would have been 19, 20. Yeah.
20. Okay, right.
Yeah. Yeah. And so I just thought, wow, the way they care for people and change lives and make a difference. And they kind of seem to be in charge of their own world in a way. There was an attractiveness to that. So, when I made my decision and started down the path, there was no thought in my mind ever that I would work for someone else. That just wasn't in medicine in this part of the country. Of course, on the coast, there were already some employment models happening at that time. But so, yeah, that's what took me down the path. I actually went to medical school to be an ophthalmologist. I had a couple of the eye surgeons take me under their wing, and next thing I know, I was scrubbed in on eye surgery, and I was loving it. This was the dawn of the cataract age and lens implant, and these people were waking up and could see, and so it was so neat, so clean, and I was like, I'm gonna do that, and so that's what I went to med school to do, and I stayed on that path very wholeheartedly until my 4th year, and 4th year, I just had kind of an aha moment, and I was married, and I didn't feel great about my application I was going to put in for ophthalmology. And so I asked my non-medical wife, I'm like, why do I not feel good about this? And she said, I don't know that I've ever seen you as an eye surgeon. I mean, you're just almost too much of a people person. Why aren't you doing primary care? And at
Mm,
the time, I said, well, no, duh, it's twice the work and half the money. I mean, what's there to think about? And so,
yeah.
um,
Yeah.
but that started a contemplative process that ended. I changed in the fourth quarter, literally, to primary care. And
So what's interesting to me about that, Kyle, may I call you Kyle? Is that cool?
absolutely, it's fine.
You earned the title, all respect. But we're having a conversation,
No,
and
we're good.
so I'm curious, like, it's interesting to me that you were thinking about this as a business, right? Because many doctors, I don't even think consider the business piece of it until after the fact. It's almost like an afterthought. And I'm sure, I don't want to put words in your mouth, but I'm sure you got into medicine for the same reason that most docs do, and that's, to help people.
Yeah.
Um, but it strikes me though that you were thinking about this as a business at an early age, and you did, kind of have that thought process of, well, wait a second, the ophthalmology thing is not pulling at my heartstrings. Um, Direct primary care seems like more of a calling, but twice the work for, you know, half the guacamole doesn't seem, like, I don't know if I want to sign up for this.
Yeah, I think it wasn't clear at the time, and this was well before the days of direct primary care. And I had a couple of mentors that I could point to that were sort of what we would call old school primary care docs that ran their own office and had their own nurses. I mean, you almost think of the old television drama shows around Marcus Welby, if you will.
Yeah.
They've got their private office and their staff, and they get to know their people, and so that was sort of the vision at the time.
Or Doc Hollywood, the movie with Michael J. Fox. Remember Doc Ock?
Well, of course, sure.
I forget his
um,
doctor. What was it? It started with an H. I don't know.
oh, I can't remember, but
Yeah.
and
Yeah.
I don't know that it was the business aspect of it as much as it was the control aspect, sort of that autonomy that they had.
Mm.
And I thought it was cool that they were their own business, but it was really that autonomy and control that I remember being very attractive to me.
Yeah, and it seems to me that we've gotten so far away. Our current U.S. healthcare system has gotten so far away from, so we're talking here a day after the New York City mayoral election, governor elections. Election day was yesterday. This will probably air in a few weeks, but. And you had asked me kind of like, what's the mood? And we talked a little bit about politics prior to jumping on. And at the end of the day, I feel like people have kind of lost their way,
Mm.
and we're getting further and further away from center, meaning with center being common sense. And in the medical profession, when I think about doctors, and let's face it, I mean, docs have been around as long as people have been around. Right?
Yeah.
There's been a go-to person in the village that you'd go to, and you'd say, "Doc, my ass is killing me," and the doc would be like, "Well, let's talk about that." Right? And so one thing leads to another, and we go from that to this model where the first word out of anyone's mouth when you call to make an appointment, if you are calling anymore, is, what kind of insurance do you have? Which seems like, well, if anyone is listening to this, you have to push back on that. Like, people ask me all the time, like, what would you change about healthcare? Well, that's one thing right off the bat that I would change about healthcare. If you call a doctor's office and the first thing out of their mouth is, what kind of insurance do you take? Your response to that should be, well, we could get to that, but what I would be interested in knowing is, what's the cash price?
Mm.
Because cash is an option. And what most people don't realize is that cash often is very good at getting you to the front of the line if we're talking about a traditional healthcare system model. And the other thing that it's really good at is almost always ensuring that you're going to pay the lowest price. But nobody's asking the question, right? Because everyone is thinking about hey, what's my share of the expense? We're all programmed to think in terms of, the copayment or the coinsurance. And it's a model that is very new historically. This hasn't been around that long, right?
Uh,
And so what intrigues me about you, Dr. Rickner, is your path, because you started out kind of right in the sweet spot of the tail end of, let's say, the golden age
mhm.
of direct primary care. And now, you've seen these changes go from, that more of that doctor patient relationship. I'm in this for the right reasons. I want to know my patients. I want to have a sense of who they are without having to refer to a chart. And we've gone astray. And so I'd love for you to expand on that a little bit, because it sounds to me like that very much was part of your process of
Mhm.
um, that kind of guided you along your career path.
Yeah, let's start with your scenario that you gave about calling the doctor's office. It's gone so far awry that the doctor can't answer that question most of the time.
Yeah.
What is the cash price? Because they've all been employed. And so
Mm,
their ability to have control over pricing, even knowing what the charges are that are going out the door with their name on it, they've totally lost that ability. And really, as I back up and sort of going back to my story, we had the advent of the necessitation and the mandate of the EHR in the offices, and that created some metrics and some qualifications that had to be followed to get paid, and the complexity of that rose and rose and rose.
and so
And
that's the electronic health record.
yeah, sorry, electronic health record. And so what that brought is a complexity, and then it also brought a costliness. So the cost of doing business went up. So
Mm,
what two things became true of American healthcare in that process is it is definitively complex and it is costly.
mm,
And so neither of those serve the patient. And so the entities that those things serve are the no value add ones that you're alluding to. And
mm,
so what happened is the complexity overwhelmed the provider. Doing business wasn't just the cost going up, it was the method that they had to do. And so along came the administrator from the hospital with the very friendly pat on the back and said, "Hey, doctor, why don't you let us worry about all of this and you just take good care of patients?" And we blindly just handed them the keys to the kingdom and
right.
said, "Here you go." And so there was the loss and the evaporation of the autonomy of the physician, which is sort of elemental to the doctor patient relationship. All of a sudden, the pat on the back person thought they owned the relationship with the patient. And
Mm,
that's where we've gone awry. And so, physicians who once controlled the transaction, controlled the time, controlled the money, and actually even controlled the process, lost control of all of it.
mm, yeah,
And the loser is the caregiver and the care recipient.
sure.
And so that's what we evolved to. That's why the name of your podcast is Broken Healthcare.
It's genius, isn't it?
Oh, beautiful.
I'm going to pat myself twice on the shoulder. All right. So, but the truth is, you said something very telling, because it's not so. I think everyone thinks of themselves, of course, like, okay, the patient is going to lose, but it's also the physician who loses. And I don't think the average person is aware of that. Like and I'm going to say, I don't want to state a percentage, because that just wouldn't be factual. But if I was a gambling man, I would say that the odds are extremely high that the average physician has no clue about what the costs are, because they've kind of handed this off now to an entity that is owned by private equity, or it's a hospital conglomerate. Maybe private equity is not involved. And the name of the game is revenue. And the patient becomes the gateway to that revenue. How many tests can we prescribe? What's the most that we can bill? And I don't think it started out with nefarious intent, right? I think back in the day, hospitals were probably trying to gain a competitive advantage as any business, is looking to compete. They're looking for a competitive edge. And I think it was kind of a slow burn, but here we are, 2025, almost 2026. And the healthcare system today, it's hard to even recognize what it used to be. And the patient is kind of one component of this, and they are kind of, they're the hub, but also that direct relationship with the physician, that one thing can make or break the entire ecosystem, if you will, because that physician now, if they are a direct primary care physician and they're not, they are not incented to order every test under the sun in the name of billing and revenue. Well, that changes things quite a bit, doesn't it?
Yeah. Yeah. I think let me just sort of tell you a story that I think it kind of highlights this transition that we're talking about. So when I had that job that I mentioned to you at the hospital, um, some of these doctors would invite me into the physician lounge.
Mm,
They had the snacks and the drinks, and well, there was a lady named Pam, and Pam made herself present in the physician lounge all the time. She worked for the hospital.
okay.
And she asked the same question of the physicians every time I heard her. Doctor, how can we help you with your patients? And there was an exchange
Hmm.
and there was a consideration.
Mm.
And what we evolved to not that many years later was, Doctor, aren't you glad we let you see our patients? It was there was a
Really?
transition of ownership
Mm.
in terms of these patients are now ours. And what I think occurred, and you mentioned just like any business, they want to get market share. It's a very conflicting thing. And we could probably do a whole nother hour on this. I know that's not why we're here, but these supposed not for profit entities
Mm.
that are there to benevolently give care to the communities in which they are have become overwhelmingly concerned with their market share and owning the entire spectrum of healthcare.
Yeah.
And it's like a race to the bottom, if you
Mm.
will.
Yeah.
And so, but in that process, we have to absorb and we have to own every physician entity that we can so that we control the stream of revenue. And as you well said, the patients are simply a representation of a stream of revenue. So it's the payer source behind them that the systems are most interested in. And no doctor that I've ever known, that was their primary interest. They're definitely interested in the patient. And so there was a shift, and that is when common sense left the building.
Mm.
And it was a transition of control, the introduction of complexity, which brought about a costliness that got out of control, still is out of control, and is on a trajectory to crash. It is
Hmm.
not sustainable. And so we as physicians, we as the providers of healthcare have got to be able to go, you know what? We're not doing this anymore. We're not taking it. We're going to do something different. Um, Buckminster Fuller has a great quote where he said, if you think something's really broken and it needs to change, then create a new model to render the old one obsolete.
Mm.
And
Yeah.
that's what we're trying to do. And
No
there
doubt.
are physicians that are proactively trying to do this, and it's turning the Titanic. And there are large forces, and there's a lot of money, but it's a fight worth having.
Well, we're talking about a $5 trillion ecosystem, right? So
Mhm.
there are a lot of entities out there that want to keep things just the way they are. And and they want to layer increases on top of it, right? The trouble
Mhm.
is most folks are not paying attention. They what do they know? The rank and file, and I don't mean that in terms of white collar, blue collar. I'm talking about everyone. The people who are getting their health care through their employers are not thinking about the true cost of that insurance policy. What they're thinking about is their cost, right? So they're
Mhm.
only seeing a fraction of it right off the bat. Employers are, and 150 odd million Americans get their coverage through their employers. It's
Mhm.
bigger than Medicaid, Medicare, and TRICARE, all the government sponsored insurance combined.
Mhm.
And so if you look at it and you say, okay, the vast majority of that population, they're not focused on the entire enchilada. They're not, the whole enchilada is not a factor. They're looking at what their cost, what their sliver of that enchilada is. And that's on the front end if they're looking at the premiums. And on the back end, it's looking at, okay, if I need to access care, what does that look like? Oh, it's a $25 copay, $50 to see a specialist. But what's the bill charge? And what does that bill charge represent to your insurance plan? Now you work for a company with 20 employees, multiply it by 20, 200, 2,000, 10,000, multiply that by 10,000. And you could see how the numbers quickly, those nickels and dimes really start adding up quick to the point now where Kaiser Family Foundation is saying the average cost for family coverage nationally is like 27 grand. That's like a new
Mhm.
car. That's a
Mhm.
nice new car for every year.
Mhm.
People just aren't paying attention. They're not looking at it objectively. And what I call it, Dr. Rickner, is I call it the casino, right? Because people they're not acknowledging real dollars. They're playing with chips.
Yeah.
Right? It's just there. No one is looking at the total cost, and the only question that they're asking is the one that they're trained to ask: Is my doctor, is my surgeon, is my hospital in network, and what's my share of this going to be? And folks, until we stop doing that, until we stop playing the games by this game by their rules, and who's they? The insurance entities, the PBMs that they own, the conglomerate hospital systems that are not, publishing their prices. They are not transparent, despite the fact that it's the law of the land. All of these entities are working. I'm not saying that they're colluding because I think they're all kind of doing it on their own, but they're all complicit in this jacking of the prices.
Yeah, I think the average consumer cannot understand. I wouldn't be surprised. Why would they? The complexity of what they're dealing with. So they can only ask about or perceive what it is that they can understand or even seem to control. So I can only choose this or this, and that's the copays associated with it. And that's where this complexity and the confusion that it creates benefits those non-value add entities that are neither providing the care nor receiving the care.
Yeah.
It's everything wrapped around it. And those entities that you refer to, our good friend Keith Smith will refer to them as the cartel. Um, and
Right.
very affectionately, I might add. And they've created the rules of the game, and
Yeah.
they're rules that they control, and they hold all the chips. And so, I think we have to, as one thing that has not changed, is that not a dollar of revenue can be generated really in healthcare without a doctor's order.
Mm.
Think about that. And
Yeah.
most doctors actually forget that. So
Mm.
there is this thing that we still can control. And then the other thing is that we are the owners of and the advocates for the doctor patient relationship, which I firmly believe is the foundation that healthcare should be built on. And so if we'll actually recognize that we can exercise some control and sort
Yeah.
of recapture some autonomy, we can change the rules of the game. I'm glad you highlighted the employer market, because those are people that vote with their money.
Yeah.
Most of those are self-funded companies, and they're beginning to go, wait a minute, this doesn't make sense anymore. My
Yeah.
costs are escalating. My claims ratio was the best it's ever been last year, but you're increasing my rates 20%. What gives? I mean, and
Yeah.
they're finally getting fed up. And we
I wish
can
I wish that were a true statement. My experience is that yes, there are a select few that are waking up and smelling the coffee, but it's not happening quick enough and not at scale, because
I
primarily the power brokers in these organizations, meaning the CFO and the CEO and the COO, are drinking the Kool-Aid, and everybody. I think the one thing that stops everyone is fear, right? Four-letter word that starts with F. And it's fear that they're not going to get the doc or the surgeon or the hospital that they want when they need it, because the other model doesn't have the big logo on it that they're so used to, right?
yeah
And and nothing further could be from the truth. But these folks are being lied to. They're being lied to by the brokers that they've developed friendships with, who aren't necessarily bad people, but it's the only model that they've known, and they're now the sales force of the insurance carrier. And it's funny that you said cartel, because think about it, folks. PBMs, pharmacy benefit managers, what do? Well, they sell drugs. They're the middlemen. They don't manufacture the drugs, right? And in many cases, they don't even hand the drug off to the patient, but they're the go between. But they are most definitely the cartel, and they're owned by the insurance carriers. So the big three: Optum, Express Scripts, CVS Caremark. These guys are owned by the insurance carriers, and they're making money hand over fist at our expense, and they truly are a cartel. So that's got to stop. Take me back. You mentioned Dr. Keith Smith, and so he, of course, is co-founder of the Surgery Center of Oklahoma. And went through a very similar, I think, experience as you did, in terms of frustration with the system, and then making a bold move to strike out on his own. And he's also co-founder of FMMA, Free Market Medical Association. Take me back to kind of the I want I'm a big I'm like a big sci-fi, Marvel, DC comic fan. I love the origin stories.
all right.
I want to know when you got bit by the spider, Peter Parker.
I hear you.
What was the moment?
Yeah, so it was a real distinct moment. Let me fast forward to where I was at. So I had I had a bit of a journey in medicine. First, I'd practiced. My first job was predetermined for me in the ultimate single payer system. I was an active duty Army doc,
Mm,
straight out of training, because I had a military scholarship.
thank you
So
for your
that
service.
yes, and it was an interesting observation about what a true single payer system looks like.
Mm,
So that was a good learning environment, and then I actually joined a physician owned practice in a semi rural setting, and saw those doctors run their practice, and what the challenges they were, with the idea that I'm going to be running it someday as well. But uh, anyway, family health concerns brought me back to my home here in Oklahoma. And at the prodding of a residency friend of mine, I did something I said I would never do. And that was, I signed on as an employed doctor with a health system. And they convinced me, it's not as bad as you think. And there was some truth in that the first few years, but the truth eroded over
mm.
time. And so fast forward 9 years into that, and having been
Well,
pulled
it
into,
wasn't a short time. You were kind of working for the man for 9
I
years.
was working for the man for 9 years, so that needs to be known.
Yeah.
But the man had pulled some of the physicians into leadership executive roles. There was a little bit of behind the curtain. So at the table with some of the negotiations, and I really didn't like what I saw, and it really just confirmed what I thought. But like all the other doctors at that point in time, it's like, what do you do? You're trapped. So I signed up for the Marine Corps Marathon in Washington, D.C., got selected to run in that. And it just happened to coincide in the same week as the American Academy of Family Practice national meeting in Washington, D.C. So my friend and partner, Dr. Lockwood, and I, we were running partners. Well, we signed up for the conference so that the health system could pay for our trip so we could go run in the marathon. And so while we were there, though, there was this little, all these educational offerings at the conference. And there was this side room about a change in the model of care. Had no idea what it was, but it was intriguing. And so that in that room in the National Convention Center in Washington, D.C. in 2014, I heard about direct primary care. And Dr. Lockwood and I were in the room together. The session was 50 minutes, and there was to be 2 follow-up sessions. But after 50 minutes, there was a break. We went out in the hallway. We looked at each other and went, oh my gosh, that's what we're doing. That makes so much sense.
Wow.
It changes everything.
Yeah.
Not only is it a model of care that changes everything, it's a business model that changes. And so we committed that day, and we went home and started drawing up our business plans and drawing out our timeline to quit our job. So I guess the spider bit me there in the hallway at the National Convention Center.
Wow, that's great. So I have to ask, how was your marathon time?
Well, through 22 miles, it was fine. And then I hit the I hit the proverbial wall.
Doctor.
And I don't know if you know anything about the Marine Corps Marathon, which is world famous.
I don't actually.
Okay. So Ray, as you know, the marathon is 26.2 miles.
Yep.
So in this particular race, the 0.2 at the end is a sharp uphill 0.2 lined with Marines yelling at you. And so I had already hit the wall and was walking, and I said, there is no way in hell I am walking up that hill with those Marines yelling at me. So I got it out the final 2, but no, I ended up being disappointed by my time because of that.
Hey, no, it's quite an accomplishment just completing a marathon. But the times blow my mind now. Like, the winners are, what are they running? Sub 5-minute miles? It's
the elite ones are running sub 5-minute miles for 26 miles. It's
insane.
Unimaginable.
That's faster than most people by far can run for 100 yards.
Yeah, right.
These guys are just all out. It's nuts.
Unthinkable. Yeah.
The New York City Marathon was just this past weekend. So
that's right.
Good stuff. So where did your paths cross with Dr. Smith the first time?
Well, that's kind of a funny story too, because after Dr. Lockwood and I got back from the conference and we were plotting our plans, we had heard about this little crazy wackadoo group of people called the Free Market Medical Association. And at that time, they were literally meeting in like a classroom.
Wow.
And so we found out when their meeting was in February. This would have been February of 15. And we went to attend that meeting, but we sat in the back. And we heard people talking about things such as we've been talking about today. And I remember Lockwood leaning over to me. He goes, if our employer finds out we're here, we're getting fired. And so that was where I was introduced to, well, let's say reintroduced to the idea of free market healthcare. I mean, that was my initial introduction that I described to you in that hospital, that I thought medicine was always going to be free market with doctors being autonomous and in control. So this was sort of we're going to take the playing field back. So that's when I first met Dr. Smith. So now 10 and a half years ago,
Mm.
um, and told him of our plans that night. And at the time, um, there was one doctor in the state of Oklahoma that had started doing direct primary care, and by the time we opened, a second one had done it. So
Mm.
it was very, very early, and it was actually crazy. It seemed
You,
very odd.
you didn't execute your business plan until after you met Dr. Smith for the first time. You hadn't opened
Right?
your doors yet.
No,
You went back,
no,
you put together a business plan. Did you put it on the back burner, which
nope,
a lot, or you were kind of, the timing was
no.
that you were just
So
in process.
yeah, so we were in process, and here's the way that it was like, okay, who's doing this? Where are they, and how are they doing it? And I don't think there was a single direct primary care practice in the country that I didn't visit their website, talk to the doctor, or we visited several of them in person. And the idea was, let's put together best practices. Let's find out how a lot of people are doing this, and so we can formulate our own. And so we actually spent 15 months in preparation before we opened the doors in
Wow,
January of 16. Mhm.
you really did your diligence. That's great.
Mhm.
You did due diligence. Episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. So, and fast forward now, today, how's business treating you? How's life?
Yeah, life is good. The struggle continues. You know, this is a fight, a war of attrition that is going to go on the rest of my career.
Mm.
We're fighting for change. Although what we've seen, January will be 10 years. Is
Congratulations.
Thank you.
A milestone.
It is. And, we've taken on the challenge at Primary Health Partners of let's scale this thing. You said a word in your intro that is very dear to my heart, and that is normalization.
Mm.
So can we move direct primary care to a point of normalization? And really, I think the access point to that are those 155 million Americans that get their benefits through their employer. And so that's been a focus of ours, that group, and just really learning about customer acquisition channels and how can we get more people in direct primary care. I mean, we talk about our mission is really to transform healthcare by making direct primary care available to everyone.
Mm.
And so that means we're looking at all avenues where people get their health benefits, and how can we make direct primary care available to those populations. So it's a major undertaking. I feel like we've come a long ways, but we have so far to go.
And so your model is kind of like a Netflix subscription. So
Yeah.
you basically, what is your, what does intake look like? Or
Mhm.
is it remote? Is it in
Mhm.
office? You putting your hands on a patient? What is, compare and contrast um, your practice and what a patient would experience and what they would pay
Mhm.
versus a traditional model.
Yeah, great. So it's funny you stole the analogy from my 29-year-old son when he goes, I don't know. People ask me what your dad does, and he said, I just tell him he's the Netflix of healthcare. You know, so yeah,
Yeah.
so our patients come to us through two main sources. So individuals that join, and those all join by clicking a button on our website that says sign up.
Mhm.
And in under 5 minutes, they're a member. And so within 24 hours, a member of our team will reach out to them, introduce them to the practice, answer any questions, make their first appointment with the doctor that they chose and the clinic that they chose. So we're very handholding those folks that do that for us. We call them client concierges, and so they usher those people into their first visit. Which that first visit for the patient really looks like, let's spend little to no time in the waiting room, and let's spend an hour in the room with the doctor. And out of that hour, that doctor might need to use 5 minutes of that time for documentation purposes. But it's really the start of the doctor patient relationship where we get to know them, they get to know us, and then we make sure they leave that day fully understanding the model that we have now become the quarterback of their healthcare team. And we are their primary entry point for all things medical. Please do not go to an urgent care. Just don't do it. Call us first, get in touch with us. And if you think you might need to go to the emergency room, you call your personal physician now. So the one thing that I love about direct primary care is it's such a levels the playing field. We take care of the very, very wealthy, but we have the poor that see us as well, and they all get the same level of service. And just for the audience's benefit, the tenets of like what does constitutes direct primary care? Well, it's that there's a flat membership rate. So those retail patients that come through the door that click on that sign up on the website with our group is $109 a month.
Mm-hmm.
And if they have a kid under 18, it's $59 a month. So that model of payment is a primary delineator. We do not bill insurance at all. So we don't have any billing and collecting, if you will. So that's one of the primary tenets. The second that is very important is that provider or physician is available to that patient 24/7. So we provide the technology platform for them to access the office or the provider whenever they need care. And then the third thing that's absolutely necessary so that you can execute the second thing is you limit the panel size. So it's completely going against the more is better. So the centerpiece is the customer service. So you have to limit the number of customers that one doctor is available to so that you can provide the service necessary. So around the country in direct primary care, 600 is a number that is floated around, but you'll see micro practices. Micro practices are a practice that is run by the doctor only. They don't even have a nurse. They don't have front desks. They don't have anything. They just take, and those practices will cap out at about 300. Our practice, we provide a lot of infrastructure for our providers. So 850 or so is a number that our providers can get to and still provide great access to care. So those are really the three tenets of direct primary care. The other half of our practice, Ray, is that 155 million people that you mentioned. So we become part of benefit plans for companies. And so the access point is their employee benefits where they can actually still choose their doctor, choose their clinic, and come see us.
Mm. And so if an employer organization with, dozens or hundreds of employees connects with you, is there some type of a discount, I would imagine, because it's a volume, it's a volume deal?
Yeah, so those adults, instead of 109, they're getting in for $84 a month. It's a really good deal.
Got it.
Yeah, so there is the employer discount. Mm-hmm.
Yeah, and so I'm glad you actually shared the cost, because I think when I hear where you're going to spend 5 minutes in the waiting room and an hour plus with a doc, and we're going to get to you right away. It sounds expensive, right? And like and the other word you used was French, concierge.
Mm-hmm.
So
Right.
I hear that stuff and I'm like, oh, this is going to be expensive. But the truth is, if you think about it, what is that, like a little over $1,200 a year
Mhm.
for an adult to receive care? That's really not expensive at all. And you
Mhm.
know, I talk to people from all over the country, and in most markets, I'm going to say that it's not uncommon for it to take longer than 3 months to get an appointment with your doctor. That's just absurd, and the reason for that is the panels are much higher, right? So,
Mhm.
and even your panels are high, but you did mention that you have infrastructure and support, and so that's not quite all on a doc. And I'm guessing that a lot of that can be handled virtually instead of in the office, and so
Yeah.
that makes sense. But I think the idea is you don't want to get to a point where now you're becoming the problem that you tried to get away from, where now access to care is taking longer. You're not able to spend as much time with a patient. Like those would be red flags, right?
100%. You have to make sure the incentives line up for the behavior, right? So, um, we left the more is better system behind. More patients, do this more, order more, refer out more. We're done with that. So, we're in a model where physicians are essentially remunerated by the number of members they have. It has nothing to do with visits. And so, as you alluded, those visits can be in person if necessary, or they could be virtual, or they could be telephonic, whatever fits the need of the patient. And, this is sort of bringing back the idea that a person who is purchasing a good or a service in the United States of America is often referred to as a customer.
Hmm.
And healthcare forgot that a long time ago.
Yeah.
And so we're reinvoking that. I mean, I was in a meeting with a potential employer group just this past week, and the CEO said, "So what's the contract?" I said, "Well, there isn't one. You can quit anytime you want."
Mm.
And we do that with our individuals and our employers. You can vote. You vote with your feet and your money. And so
I love that. I love
we're
that.
not. Yeah, we're not going to hold people hostage.
Yeah.
That that's not how a relationship is. You don't hold people hostage to make them your friend. You they can leave anytime. And so
Yeah.
again, it's a customer. And so that's that free market principle that's so important. That and the relationship works because the physician chooses to be there and the patient chooses to be there. They're not both placed there by third party entities that require them to be there.
Mm. I love that. We've gotten way, way, way overcomplicated with everything in this culture, and there's a contract for everything, and the contract can't be a paragraph. Oh no, no, no,
Mm.
that would be absurd. Why not make it like a telephone book? And it's such nonsense. Like what happened to a spit and a handshake, or how about this? My word is my bond, right? Like
Mm.
you don't see that anymore, and so that really is refreshing, because the bottom line is you're saying, hey, we we're here to deliver as promised, and if at any time we fail to deliver as promised, then just cancel us,
Yeah,
right?
we do have an agreement that they acknowledge, but that agreement is really saying, "Hey, this is what we're going to do for you,"
Right.
and
Yeah.
it's not binding.
Right.
So yeah, I think it's an
Yeah.
important thing that we are doing in terms of letting people choose, because choice is what makes the whole thing work.
So you have to unpack one thing for me. You it so you're almost 10 years in,
Mhm.
and based on what you shared, I I surmise that it's not all roses. you are still, I think the word you used or the term you used was fighting.
Mhm.
And so the question is, what exactly are you fighting? And is it what's the word I'm looking for? Is it is there a reason that you're in this fight? What
Mhm.
what is, unpack that for me. What's going what why isn't it easier to
Yeah.
do what you're trying to do?
Well, let me start by saying this that, some people get to have a job, and some people are fortunate enough to have a career. And then you hope you're one of those people that have a calling.
Mm,
And for me, this is a calling. And it is just a burden that I carry around, that this system that we live and work in is so broken. And I need to at least do my part to change what is happening. And you alluded to it earlier when we were talking about the cartel, is that most people that are voting to just hit the renew button on their benefits every year, they do so for two reasons. One is it's the easy thing to do, and two is they don't understand the alternatives.
mm,
And so I am seeing more and more people in those decision processes going, wait a minute, let's talk about this, and what can we do? And we started with our first little company of 22 people in February of 16, and now we take care of 240 plus companies, and some of uh, good size. So I think that we're seeing a movement. We're
mm.
seeing a revolution in healthcare where the people that are voting with their dollars are doing so conscientiously. They are open to innovation and creativity in the marketplace, which I know you're all about.
Yep.
And so we're seeing it. And it's so the fight is against the cartel. It's against the status quo. It's against what has become normal that absolutely does not benefit those involved in the care cycle. And so those caregivers, and this is passion of mine, is that when I was an executive physician in the health system, I realized how all my colleagues are frustrated and fed up. This was not the dream. This is
Yeah.
not why they spent the time and money and energy to go down this journey to be a physician. So, I
Yeah.
mean, we really started realizing as a secondary thing that we need to try to rescue these folks.
Sure.
We got
And
to
that,
have
yeah,
doctors. Yeah,
when
we got to have doctors that love what they do again.
when you
You
say
know,
that, you mean quite literally, because one of the highest suicide rates are
100%.
physicians, right?
Well, a
It's
physician kills themselves every day in the United States, every
wow.
day.
Wow.
And so, yes, I do mean quite literally. And also, those folks that were so fed up, they're ready to quit early. They're done. They're going to go do something else. And we already have a critical physician shortage in primary care.
Mm,
So, literally rescuing them so that they can practice medicine the way they always hope to, and have time with patients, and do it. And so there's so much more of this. This is not easy. I mean, these health systems promise, they wave the golden banner. Look at this really big initial guarantee we're going to give you, and
right.
come play in our playground, and then they get stuck. And so we have a lot more to rescue. So the other part of the fight is that the physicians are ending up where, honestly, in my opinion, they were never meant to be, and that is in the employment of a hospital or sick system.
Mm,
Their incentives
mm,
and motivations for employing primary care doctors are wrong.
mm.
They're simply there to help them capture revenue.
Sure.
That's the only reason.
Yeah.
And so you become captured. That's what
Yeah.
happens. And you
Yeah.
become constrained. You lose all autonomy. And they do it by waving the big golden banner up front. And it's working.
Yeah.
So we're fighting that. We're fighting the traditional benefit design and stamp hit renewal, because the people that benefit from that are the big players holding the chips in the system that you. So the fight is at multiple levels, where we needed to get it back to an autonomous environment that's free for the physician, a patient-centered, customer service-oriented environment for the patient, and a fiscally responsible environment for the employer that's paying all these dollars for care.
How involved is your organization in helping a patient seek a specialist or a surgeon or a facility? Are they on their own for that, to a large extent? Do you get involved in, helping them? In healthcare, it's counterintuitive, right? But the lowest cost is most often the highest quality, and
Yeah.
it's we see it time and time again, and it is, quite counterintuitive. But
Mhm.
for someone who's listening to this thinking, well, what happens if, I have a heart attack and then I need to follow up with a cardiologist? Like,
Mhm.
how does that work? And where I'm going with this, Dr. Rickner, is, um, are you finding that as part of the challenge? Is that one of the hurdles? It's helping, or the access, I should say, to care that goes beyond the scope of what your folks can deliver.
It's certainly part of the challenge, but it is one that we are slowly winning. We play an active role in that. So by far the best advocate for the patients are primary care physicians,
Mm,
and we have become the market experts in our area about that lowest cost, highest quality care. And as we have grown, it turns out that specialists would like business. They would
mm,
like referrals. And so I'm pleased to say, at least in our major markets here in Oklahoma, that we're seeing a return to the old ways of the specialist and the primary care working together for the good of the patient.
mm.
So more care is happening outside of the health systems than ever before. And so, yes, and then one of the most rewarding things that we get to do is actually be at the table with some of our employer partners as they're talking about their benefits, their benefit design, around what should we do, how should we go this way, because there's no incentives that change our world.
Mm.
And so all of a sudden we're helping create care environments with coverages that can benefit the patient and be cost effective to the employer. And so it takes work, right? So that's not the easy button. But once they do it, they just don't want to go back.
Yeah. Oh,
When
the
they,
experience, the customer service experience, right? You use the word customer.
Mhm.
So patient, yes, but also customer. The customer service experience for people that go to a DPC that's not ensnared and trapped by the system. It's in your model. It's a night and day experience, night and day. I could tell you firsthand because I switched to a DPC doc myself, this past year. It,
All
it just
right.
kept, well, dude, it kept coming up. I was like, I had Dr. Keith Smith on the show, and I told him, I'm on my wife's plan. She's a speech pathologist, blah, blah, blah. He's like, you got to get off that crap. What? So, you hear a guy like him who's, one of the top of the top. Some of the smartest consultants I know are, now with faith-based, cost sharing plans as
Mhm.
opposed to health insurance plans. But once
Mhm.
you have the experience and you realize, hey, this is a fraction of the cost, I don't think there's any turning back. And I think what people really don't appreciate is the fact that the direct primary care physician is the gateway to all things medical care. And if all things medical care is revenue profit driven, then how can you trust that what your doctor is telling you is right if their very income is derived on a bonus system, RVUs, that have to do with how much revenue they drive for the healthcare system that they're affiliated with. Can you really trust that you need that MRI, that you need that CAT scan, that you need these major diagnostic exams, multiple tests? It just seems to me that it's worth asking the question, at least, you know, is there, are we going like straight pedal to the metal with what your recommendations are, or is there, somewhere on the spectrum where you can kind of guide and point me that might not require all of these very costly exams? Because what people don't, what they fail to acknowledge again is where they're playing with house chips, playing with, in this big healthcare casino. And at the end of the day, each one of those exams, even though their costs may be a fraction of the true cost, it's an $8,000 major diagnostic exam at the hospital versus $800 down
Hmm.
the road at a freestanding radiological clinic. It's a $150,000 operation as opposed to a $30,000 operation at Dr. Keith's, surgery center of Oklahoma. All of these things add up. And when you multiply it, it's like, oh my God, like we are literally talking about millions and millions of dollars at small scale. At scale, we're talking about probably over $1 trillion of waste, fraud, and abuse in a $5 trillion system. And so it might sound like, bombastic or sensational, like to hear me saying this stuff, but a direct primary care physician is the gateway to all of that other stuff.
See, Ray, you're proving it. We're winning the war of attrition, man. You yourself joined up a year ago. So I do, I mean, great description. And it is something where, and I'm coming on 10 years of doing this, and I have yet to come across the person that engages direct primary care as a customer and experiences it and then says, you know what, thanks, but I kind of prefer the health system clinic. I think I'll go back there.
Mm,
It just doesn't happen now. um, their financial incentives with their health plan may force them that way, but they often go kicking and screaming.
mm,
And so you're right. And those dollars that you're talking about, that they end up in someone's pocket somewhere.
yeah. Oh, for
It,
sure.
and
There
and it's just the wrong pockets.
plenty
And
plenty of hands out. Oh,
uh,
that's my dollar. No, it's my dollar. It's you know
yeah,
what? There's enough to go around. You take a dollar, and I'll take a dollar.
yeah. And you've alluded to it several times, but the big picture is the percent of GDP that this country spends on healthcare is so far out of the norm of the whole world, right, Ray?
Yeah,
And it's gone. We're hitting about 18% now, and in 1960 it was 5%.
yeah,
And our cost is right at 18,000 per person per year, is
yeah.
what that works out to, and it was $1,000 in 1960. So it is actually, and really the onset of that is anytime there's a third party involved, costs go up. Period. And
Yeah.
so we've got to cut out the middlemen. So there has to be this systematic process. The more and more medical services that we can do directly
Mm,
and take out third parties. And
yep.
that goes for even specialty care. Ray, it goes for surgery. I
Yep.
mean, I have had patients that have coverage and they needed a surgery. We paid cash for the surgery because that was actually going to cost them less than using their coverage.
And they're out of
That
pocket. That's crazy,
yeah,
right? Yeah.
that's the new frontier. And so the more that we're willing to be innovative and creative, and specialists in primary care work together for the good of the patient, we're going to win this war. And I think eventually the people who spend the most money in this country, those employers that you mentioned,
Mm,
eventually they're in a critical mass number. They're going to vote with their dollars, and this way of doing business that we're doing now is going to lose. You cannot continue to do the wrong thing over and over and over time and hope to win. I think
Yeah,
you're going to lose. And so we're going to do the right thing in the right way for the right reasons. And I think we're going to win in the end.
I love it. Um, I want your opinion on a couple of things before I let you go. One is I think it's pretty clear that what we have now is a sick care system, not a healthcare system, and so we didn't talk about this prior, and I don't know if this is part of what you do today or you've kind of toyed with the idea because what I'm about to say would cost the practice money, but do you spend time doing blood work and then reviewing that with a patient and not saying as a regular Western medical doctor might say, oh, you're within the acceptable range, which is what we hear all the time. But are you optimal or are you not optimal? And what can you do to get optimal, right? It's like I almost feel like we have a culture and a society where, we hear things like fat shaming and this and that and come on. Like you are having a relationship with your doctor, a conversation with your doctor. It's sacrosanct. There's a doctor client relationship there, and your doctor should be free to tell you that no emperor, you're not wearing any clothes. Of course, I'm wearing a flimsy gown. That's what you gave me, but tell it like it is. And if a patient is obese, have that conversation. And maybe the first go to is not, going with a GLP-1. Maybe the first go to is, and listen, I know that this is one of the most difficult things, right, to get people to change behavior. But I don't think enough of those conversations are had in the traditional model because frankly there just isn't time, right? Your colleagues are just stressed, overloaded, have to keep up with the electronic medical record. There's just no time for this stuff. But it's the long-winded way of me asking, is that part of your practice? Do your docs try to dive deeper and get people before it's too late, before their sugar, their A1C, whatever is off the charts? Is that part of your plan, or is it right now you have your hands full just taking care of people?
No, so think about this. If you think for a second about those people that you would call they're my best friends, they're my real friends, they're inner circle people. They can be honest with you about things that you wouldn't necessarily allow others to talk to you about.
Mhm.
And when you have a developed, trusting doctor patient relationship, these conversations get opened up. And so you have this ability to discuss health in a way that's real. And you're not just looking for a solution as quick as possible. And you can be real with them about, hey, man, you weigh too much. It's because you eat too much and you don't exercise and
Yeah.
you don't sleep good. And
Yeah.
so I'm not giving you a pill or something. You're going to have to start behaving better. And you know
Mm.
what? I'll see you every month for the next year. And we're going to bring you here and weigh you and check your blood pressure. And if you're misbehaving, we're going to know it. These are the kind of reality that we can deal with. And
Mm.
honestly, I think that's one of the most enjoyable things from our doctors. I want to tell a quick doctor patient story from our practice that this really occurred. One of our great doctors, Dr. Bourne, she got a new patient, quite an overweight gentleman, and she did his lab work, and he was well into diabetes,
Mm.
and he had a job that was driving a truck. Schedule was tough. He lived on his own, um, and so she started talking to him about diet. These are the kind of things that you should eat, and avoid this. And he's like, I'm not even sure what you're saying. And she said, okay, I'll tell you what. Um, we're going to have an appointment next week.
Mm.
And he's like, okay. So she said, but we're not going to have the appointment here at the office. I'm meeting you at the grocery store. She walked the aisles with him for half an hour and helped him pick out stuff.
Wow.
And so that sounds outlandish, but that is the level of impact that a physician can have. And when people are dealing with difficult diagnosis that might require a specialist conversation that's difficult and complicated, Ray, without any prompting, I've had some of our doctors go to the specialist appointment with their patient, sit in the room with them. And so the depth to which we can be invited into their lives through that relationship and talk about the things that really matter and not just shortcuts and quick fixes and band-aids. Yeah, we can impact health on the preventative side. And there's actually data out there that supports what direct primary care can do in terms of helping people with obesity and diabetes and high blood pressure and other measures that they aren't waiting for the sick system. They don't end up on the table getting the bypass surgery. They deal with things ahead of time. So absolutely, we do that. It's one of the joys of what we do. It's one of the reasons doctors love to do this.
Yeah, I was just watching Squawk Box, and they had I think it was doctor of psychiatry, I'm not sure, from Harvard, who was written books. He's well published, has a podcast. I'm sorry, his name escapes me. It's the first time I've ever seen this guy, but he said something very telling. He said, why 90 upwards of 95% of diets fail. He said it's because the reward at the finish line after you've lost weight is that you get to continue not to have all the foods that you love. And what he was saying is, like, mentally, it's about the journey. We can't like program people to think that a diet is the solution if there's an end line where now you could go back to your old behavior, because that is only going to prove out to do one thing. You're going to not only put on the weight that you lost, but you're probably going to add some pounds on top of that. And so I think it's really critical. It kind of is a segue to the other thing that I'd love for you to opine on, which is, how do you feel about, forget about, the politics of it, but the new administration, led by Secretary Kennedy with Dr. McCary and the other folks that they have there, as an outsider, who, outsider being not political, but as someone who is astute, who's learned, who's a medical doctor, for crying out loud, what do you think of this? Is this a good thing, or is it a bad thing? Are they calling out, like the AMA and these other institutions that have existed for years and years? What's your opinion about what has happened at the FDA and the NIH? Are these organizations that, well, it's about time that there's change, or are you kind of appalled that all of these changes are proposed or going on?
Wow, Ray, why don't you just open up 4 cans of worms there? Well, let me just start by saying that I've never looked to Washington to solve my problems, and I think too many of us do, and you can put me wherever you want on the political spectrum, but that's legislatively, we're not going to change lives in a way. So I'll start with that, and then I'll say it's never a bad thing to examine what we put in our bodies in terms of, is this good or not? And so you can argue about the methodology and the pace at which maybe some of those things are happening, which can be a bit of a concern. But we've definitely had a pollution in the food industry to a point where we're fatter than we've ever been as a society. There's no doubting that. So it's perfectly fine to look at contributors to that. It's a multifaceted problem. And then in terms of what we approve at the FDA, Um, as a side note, we haven't really talked about it, but I've been involved in clinical research trials for 15 years.
Mm.
This has been a part of my medical professional life for a long time. We have to have a process of evaluation that is rooted in science and evidence and safety. And we've had that for a long time. Um, the process has, like everything else in America, almost become too complicated and too costly. And so those consumers on the other end of those prescriptions end up feeling some of that. So definitely some reform in that area has to be looked at. It just can't be this hard, this expensive, this long and complex to bring things to market. You can certainly evaluate efficacy and safety in a reasonable time manner. So, um, just like all big government entities, corruption abounds.
Mm.
It's everywhere.
Hmm.
You're never going to solve for all of it. Um, but I think taking a stab at the status quo, we've been talking about that in healthcare forever, but I would say not only is healthcare broken, but American government is broken in so many ways. And so is it wrong that we look at how we do those things? No, it's not. Do I line up with all of the opinions being espoused at that level? Absolutely not.
Hmm.
But I am a big proponent of evidence based trials and science that brings things to market. But I don't think we need to continue paying for all of it here in America. Everybody's aware of the way the pricing structure works, where exorbitantly priced drugs in this country are easily accessible and affordable around the world.
Mm.
One of the best stories around that was actually a pharmaceutical rep that called on me with a diabetic pill that had come to market, and she herself was on the medication.
Mm.
And this medication, at the time that we were talking, if you wanted to buy a 30-day supply, it was about $600 a month. So
Mm.
literally $20 a day. So a pill was $21 actually at the
Mhm.
time.
Mm.
And she went on vacation. She actually went to Dubai,
Oh.
and she got there and realized, oh no, I forgot my diabetic medication.
Uh-huh.
Oh no. But like many countries around the world, they have open market pharmacies. So you literally can just go in and go, I need some of this. And she was like, oh no. I mean, let's pull out the cash we were going to spend on, I'm going to be here 7 days. It's going to be all this money. And so she said, well, I need a week's worth, please. 7 pills while I'm here on vacation. And they said, well, that'll be $21. It was 1/10 the price,
Yeah. Yeah.
and this is still a truth. So there's an inequity there that we need to solve for. I don't think the American consumer should pay for 100% of all clinical research, and the rest of the world gets all this benefit for free. So there's an inequity there.
Mm.
I never think it's wrong to evaluate the safety of what goes into our body by way of medications, vaccines, or food. But I'm also not a proponent of excessive regulation in that sense either. So I don't have all the answers, but I do realize that the way that maybe my grandparents ate is not medically advisable.
Yeah.
But yet their cancer rates are much lower than ours.
Right.
So there's some correlations and it's okay to look at that stuff, and make sure that people that profit from the products that we put in our body are not doing so scrupulously. So
Yeah.
there's my political answer to your political question, right?
Listen, we could go another 3 hours on that. So
Yeah, yeah.
why don't we leave it there? So Dr. Rickner, again, the name of your organization is
Primary Health Partners.
Primary Health Partners, and how do folks find you?
Yeah, so primaryhealthpartners.com. So it's actually primary-healthpartners.com. And you can see our practice, see our providers. We have brick and mortar offices in Oklahoma City and Tulsa, Oklahoma. But we now use a network of almost 600 direct primary care doctors around the country to execute care to some of these wonderful employer partners. So we have lives that we take care of in more than 30 states now.
Wow.
By leveraging that. So no health system can do that, Ray. They cannot leverage care over so many state lines for employers that go over state lines. So that's just one of the many reasons we have to keep fighting and winning this struggle.
Right on. Well, hey, we really appreciate you joining us today, Dr. Rickner. It's been a pleasure. And folks, there you have it. You heard it right out of the horse's mouth, if you will. No pun intended. He's in Oklahoma.
Right.
But at the end of the day, you have the ability to take your healthcare back, and it all starts with your primary care physician. So thank you so much, doctor. Folks, until next time, love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.